Hello guys, welcome back to the book of Perfusionist by Jazadar. So today there is one question for you from Manuk Jaja. The question is
Manu Jaja is my the follower who continues keeping me motivated and energized by the questions. Thank you so much, Manu Jaja. So, what is the question from the Manuj?
So the question from Manuk is that sir please
Manuk,
explain.
sorry, no, not Manuj. Manuk Jaja.
Yeah. Question is that sir please explain initiation of pediatric cardiopulmonary bypass.
See, adult cardiac surgery initiation bypassing and for the pediatric cardiopulmonary bypass initiation we have different actually way and strategy to keep ready yourself for the pediatric cardiopulmonary bypass initiations as a perfusionist. Of course, we have to calculate the body surface area of the patient by calculate with the height and weight, and then we find out the calculated blood flow. But usually in adult surgery, we have a huge intravascular volumes like 3 to 5 liter, and by mixing of your priming volume in around a liter, it will not make such a difference in blood factors concentration and even the blood factors concentration and even the blood clotting factors concentrations. So by adding, so if, as compared with a pediatric surgery or a neonate surgery, we need to design a short circuit and with a small tubing circuit, and according to the body surface area of the patients, and we have to select the small size oxygenators according to the BSA of the patient and the small size of the circuit, and then we have to find out the priming volume of our priming circuit, and then before going on the bypass we have to calculate the hematocrit on bypass, how much we are getting the hematocrit on a pump. So we, according to that, we have to added the either a whole blood cell or PRBC, and of course albumins, which keep our circuit intact and avoid massive hemodilution of the patient. Secondly, we need to know all the BSA sizes of the valve sizes before going on the bypass, so that will going to help to the surgeon to do. So before going on the circuit, we have to finalize the size of our extracorporeal circuit, the size of the neonatal or an pediatric size of the membrane oxygenator, hemoglobin hematocrit formula, the size of aortic and with venous cannula, and of course the hypothermic temperatures. So these are the things we have to take care of during the cardiopulmonary bypass initiation of the pediatric surgery, and of course with the best communication between surgeon and an anesthetist is the most important. Mostly we are doing ultrafiltrations in a cuff and a muff for a pediatric surgery, because the body mass of a pediatric neonates is smaller and as compared to the adult, and the priming volume of the pediatric surgery is the less, and by adding even the 50 mils will going to make a dramatically change in the hemoglobin and hematocrit dilutions and even the blood factor dilutions. So this is the reason by adding priming volume and deciding the priming volume, we have to keep the oncotic and osmotic pressures in a normal level, so that we will not create a more dilution which create a third space cavity. So, and this is the reason we always keeping like a ultrafiltration and modified ultrafiltration throughout the bypass in a pediatric surgery. Last but not least, your cannulation selections, circuit selections, hemoglobin level, hematocrit level, pH level. Usually some of the procedures where you need to go the blood gases management in the pH management system you are required, and few of the cases you the alpha stat management. So here in a pediatric surgery, some of the centers they are using alpha stat, or some centers using the pH according to the procedure complexity. Pediatric perfusion is a much challenging as compared to the adults. So in pediatric surgery, you have to complete do your complete homework as with the pre-op checklist and with your pre-op formulas to manage your hemoglobin hematocrit and blood factor during the cardiopulmonary bypass, providing to reduce the bleeding. So we have to keep always hemoglobin in right 9 to 10 gram per deciliter during the bypass. I try my best to answer for the pediatric initiations, and one thing more just I need to add. So the time of your initiating the bypass, so we always keep sweep 1 to 1, and we always keep the FiO2 and 100% in the initially, and then we'll decrease according to the PO2 of the patient, the sweep gas of the patient. So mostly if you have the cyanotic patient, we didn't decrease the PCO2 in a dramatically. We keep slowly to decrease the PCO2 level, because the patient is dependent with a higher PCO2 level. So we go according to the management of the PCO2 and even the FiO2. I'll try my best to answer as much I can. If still you have the question queries, please you can put a question under this video, so we'll try to answer. And my colleagues in the world, they are ready to, if they want to give their input and their knowledge experience in my video, please carry on. So have a nice and very good day. Take care.